welcome to our Lunch and Learn focused at secondary school children. I'm Laura Cassidy. I'm the Network Delivery Manager for the Child Health and Wellbeing Network in North East and North Cumbria Integrated Care Board, and I lead on the Healthier Together website and mobile app as part of our integration programme. I'm going to hand over to Dr. Emma Lim, who's going to introduce herself, and then I will just do a slight introduction to the network, and then Emma will take over for the session on the clinical aspect.
Hi, my name's Emma Lim. I'm a consultant paediatrician at the Great North Children's Hospital, and I'm co-clinical lead for the Healthier Together programme. And welcome, everybody. Now let's see if I can move my slides.
So just a bit of context setting and around the work that we do as a network. Obviously, I think you'll all be aware in the fields that you work in that as a region we have quite significant challenges when it comes to health and wellbeing outcomes for children and young people, and you can see there some of the statistics around that, and that is some of the stats that drive a lot of the work that we do as a network, particularly Healthier Together. You can see there we've got the highest rates of A&E attendances for children aged 0 to 4 in the region in the country, and actually, you know, Healthier Together is about supporting that work and trying to ensure that parents have consistent health advice. We've got high rates of asthma admissions, and actually, you know, asthma is a significant challenge in that children are still dying in our country, and the rates of asthma deaths have actually risen in recent years. So it's a big significant area that we're doing a lot of work on as part of the Children and Young People's Transformation Programme. And I think, you know, what obviously exacerbates some of these challenges as well is the levels of poverty that we focus on, that we have in our region, and obviously the challenges that leaves families in relation to be able to address their own health needs. So a lot of the work that we do as a network is very much about collaborative approaches, testing innovations, models of good practice, learning from them and sharing that learning. If you move to the next slide, please, Emma.
Sorry, it's my...
Okay, it's all right. So the network was established in 2018, and we've evolved over recent years in relation to, we were part of NHS England and we now sit within the Integrated Care Board. You can see there our priority wheel, and this was developed with health professionals and children, young people and families around what was priorities to them and how could we support that work. So you can see there things like childhood illness, poverty, lots of other things around health conditions, and in that centre there is central to that is children, young people and family voice. So we have a young person's board that works with our strategic oversight group as part of the network to support any decision making and development of programme work. As a result of COVID, we went back out to the system, and you can see there that family support was added, and that was very much driven by as a result of COVID. And I think you can see that a lot of the work that services are doing and that we're involved in is around that wider family support and supporting parents and children. The vision of the network is very much that we believe all children and young people should have the opportunity to flourish and reach their potential and be advantaged by organisations working together. And as I mentioned, very much a lot of that, what we do to do that is what the system wanted from us, was share good practice, drive work forward and connect expert groups. And Emma's an example of how we do this work with our links with our clinical advisors, clinical leads, and broader advisors from across the system. Next slide.
Oh, my slides don't.
I think it's just sometimes Teams as well goes on a go slow. And the key areas that we focus on is delivery wise areas are Children and Young People's Transformation Programme, our integration programme, and that encompasses work around service improvement, around asthma, epilepsy, transitions, diabetes, mental health and paediatric early warning signs, and the pilot work we're doing in our region around complications of excess weight. We also deliver wider work on delivering and tackling health inequalities, and you can see there youth mental health first aid, poverty proofing, and the South Tees Arts Initiative, which is a dance initiative with a family support element, is part of some of that wider work that we've done, and the development of the Core 20+5 toolkit for children and young people with that broader North East and North Cumbria lens. So lots of different elements to the work that we do to address health inequalities and improve outcomes for children and young people. So what
Sorry.
What I would do as well is if people aren't members of the network, there is a slide in the slides. If you'd like to join, we do send out lots of bulletins and information, and which may be of use to you that you'll find useful and support. And it may be how you've come onto these courses already. But if you haven't already done so, please do join. And I'll hand over to Emma to start the clinical session. Thank you.
Hello, and welcome back to some of you. Today I'm trying to focus on older children, so I'll do a brief introduction to Healthier Together, although I hope you all use it. I've picked some acute conditions, of which we've got many, but these are ones that I think that are just really useful. So I'm going to talk about sepsis, fainting, and testicular torsion. There's a really current thing about that. Injuries, it's really nice to see people from minor injury units because we've got a page on that. Things that we see commonly in teenagers are really all problems around puberty, and some extra things about young people's pages, and something about alcohol. So I'm hoping that you've all used Healthier Together. It comes in two forms. We've got the website where all the information is, and there's two sides to that. There's the parent information and there's the professionals information where all our pediatric pathways are. And it's completely open and transparent. So if the parents want to look at the professional side, that's absolutely fine. We also have the app. And the app is really important because it's connected to GP surgeries. So using this, if you had an Amber thing where you wanted to ask questions, you can send a text straight to your GP. Our website is actually going under a redo, so it's changing to a different provider and is going to get a whole new facelift and look really modern and beautiful, we believe, which will be later this year. The real main thing that's important, and this is on the parent side, as we use a traffic light system. This is one of the standard pages I use all the time, which is fevers. And you can see here, there's a bit of information about fevers. And then the red section, I always say to parents, if you have any of these problems, and there'll be things like seizures, they're really obvious, drowsy, confused, then I want you to bring your child straight to the emergency department. If you have any of the Amber symptoms, you can contact 111 or your GP. And if you're on the app, that would take you straight through. But the majority of the children we see, and this is what I say to parents, is if you don't have the red or amber symptoms, if you're in the green section, it doesn't mean your child is completely well. But it does mean that your child is safe to stay at home. And then there's some home care advice at the bottom. And so it's just trying to encourage and empower parents and families to stay at home. I think it's really easy to focus on this sort of acute conditions because you sort of think of them, but actually we've got a huge number of resources. I've just put up this page. You see we've got our asthma referral pathway. We've got links to Beat Asthma Friendly Schools. So all the work for asthma for schools is on here. We've got videos, webinars, and sort of related things. So we've got vaping here, which is very current. And if you, like me, have teenage children, they'll tell you that everybody is vaping in the toilets at school. So we've got professional resources, communities resources, webinars, and referrals. Because we're talking about schools, this is one of my favorite pages. I think that it's a real drive to keep children at school appropriately. So this is a list of conditions, and some of our schools use it really successfully. So these are things that you can come to school with. So you can come to school if you've got lice. I know they don't like it, but you can. These are things that you can consider may be appropriate depending on how sick your child is. And these are the things you shouldn't send your child to school with. And what some of the schools do is if the child is off, they'll go through with them and they'll check that it's for a red reason. And if it's not, they'll say Healthier Together says it's absolutely fine. Please send your child in. So this is a great resource. So now I'm moving on to sort of specific topics, and I just put up sepsis first because we've just recently finished an e-learning module on sepsis in the community. So this is on NHS England, and we have a specific pediatric section. So please have a look. It only takes 5 minutes and there's loads of information. And you should be able to log on because you have a NHSE login for various other things that you'll have to learn about. But briefly, I want you to think about these kind of teenagers who are at high risk of sepsis. The thing about teenagers is we see a lot of little preschool children with fevers. They go to nursery, they're meeting viruses for the first time, and like literally every month they have a temperature. But as you get older, it's much less common to get fevers, and it's less common to see children. So if I see a teenager with a fever, I immediately have a red flag because teenagers don't want to come to hospital or to see the GP. So if they've got that far, there's probably something not right. The ones you really need to be worried about are the unimmunized. We had a really tragic case in a local school maybe 5 years ago now, where they were doing the meningococcal vaccine immunization in the teenagers, and a boy came in and said, "Can I have my vaccination?" And he came from quite a chaotic house, and they said, "Oh no, your mum hasn't signed the form and you can't, even though you are almost 16." So he didn't get immunized, and within 6 months he came in with meningococcal sepsis and died. So really think about anybody who has missed immunizations, about refugees, about people whose immunization status you aren't sure of. The other ones who are really at risk, so if they had a fever after recent trauma, surgery, or any invasive procedure, and it was less than 6 weeks ago, they're more likely to have a serious bacterial infection. So they're the ones who should ring alarm bells to you. Think about children with impaired immunity. It's easy to remember the ones with primary immunodeficiency because they're kind of like really unwell. But nowadays, we have a lot of children out in the community with things like Crohn's, inflammatory bowel disease, juvenile idiopathic arthritis, who are on monoclonal antibodies, and they are more likely to get sick. They have impaired immunity. So think about what drugs they're on. Any children with chronic illness, so any child with neurodisability or chest disease is at higher risk, and any child with indwelling lines or catheters. And I always talk about things when I say impaired immunity. The common thing is we see children who have something like chickenpox or COVID, and actually their immunity is functionally affected. So the next month or so, they don't fight off illnesses as well as they should. And you must always think about, do they have a secondary bacterial infection? There was a case in Alder Hey where a child went in for a routine endoscopy, and it was 3 weeks after chickenpox. All his spots had cleared up and dried up. He was really well in himself. He went in, he had the endoscopy, and he developed sepsis afterwards. And it probably was as a result of that. And now they do not have any elective procedures there until it's 6 weeks after chickenpox. So these are the sort of red flags if a teenager comes in with fever. Also think about fever for more than 5 days. Having said that, everybody with flu B this year had fever for more than 5 days. But if I did a test and I knew it was flu B, then I have a reason for it. And the other thing is fever and abdominal pain. We see a lot of children with fever and we see a lot of children with abdominal pain, but we don't see a lot with both. So that's a sort of trigger to think about things like appendicitis. I think limb joint swelling, cellulitis is fairly obvious, but also if somebody is brought in by a parent or carer. So it was a couple of years ago now. I had a teenage boy brought in by his mum. It was after Christmas. And she said, he's been in his room since Boxing Day and he won't eat anything. She said, it's normal for him to be in his room, but normally he'd eat me out of house and home and he won't eat anything. And when we said to him, what's wrong? He was literally like, nothing. My tummy hurts, nothing. And he had appendicitis when they did the laparotomy. When they put the laparoscope in, the pus from his abdomen was under such high pressure it hit the roof of the operating theatre. So when there's something different from normal, it's worth thinking about that. This is our sepsis pathway. Just go and have a look. I've gone through the red flags for you, but what's useful is it gives you all the things to look for, and we have got normal values on the second page, so you don't need to have to look up, is this pulse normal for a 3-year-old or a 5-year-old? So it's just a real reminder that fevers in teenagers is not quite like fevers in preschool children. It's less common, and I'm always a little bit more wary. That's moving me on to something much more common, fits, feints, and funny turns. I thought I'd bring this up because I see a lot of this in my clinic. It's pretty straightforward. It needs a good history, an examination, and one ECG somewhere. This is a child who's definitely fainted because they've dropped their phone. And I'm making a joke of it, but one of the most important things about fits, feints, and funny turns is that period of observation. So often we get people who come into the emergency department and say, I'm fainted, something's really ill. We put them in a bed, and the nurses will do a set of observations, and then we might go away and we walk past them a couple of times. And I always look to see what they're doing when I'm not watching. And I've seen some of them who, when you go up to them, they say, I'm drowsy, everything is wrong. But when they think I'm not watching, I've seen them taking selfies and texting their friends. So just that observation, both when they think that you're looking and when they think you're not looking, is really useful. We've got a great pathway for fits, feints, and funny turns. So the main thing is the history. Find out what was happening before. I see hundreds of teenage girls in my clinic. They almost always didn't eat breakfast. They've been sitting in the class for a long period of time, like 40 minutes, and then suddenly got up and then felt faint, which is very common. What happened during the episode? Did they collapse? Did they change color? Did they have any altered consciousness? Did they make any funny movements? Were they incontinent? Did they get any injuries, any tongue biting, for example? And it may be that you need to get that story and that history from a friend or whoever was there. And how did they behave afterwards? Were they sleepy? Was there any unusual behavior? Did they have any asymmetry or limb weakness? Could they be distracted? Does it occur when they were exercising? Any other history you'll probably know about, but just remember a history of similar events, epilepsy, or sudden cardiac death in young adults, in family members. The examination, you need to do a quick neurology. I often just get them to walk around to look at their gait. A cardiac examination, which I really mean heart rate and blood pressure. It's really important if there's more than one or if there's some worry to get parents to video events. If somebody can get a video, that's so useful. And they usually need one ECG. As long as they've had one ECG, that's fine. The sort of children we want to see the same day, any with abnormal cardiac findings or abnormal ECG, abnormal neurology, obviously raised intracranial pressure, so any blurred vision, headaches at night or in waking and persistent vomiting, any child who's really unwell, but this is not usually them, any who are confused or have developmental delay or aggression. So those are the ones that I would send in immediately. The majority in the teenagers are just faints, but faints look really dramatic. So if you haven't seen somebody faint or it's the first time, it actually looks like they're really unwell, and they can feel quite unwell afterwards. Remember, we've also got a first fit clinic if you think it was a fit. So I'm moving on from faints to balls. Not this. This is the Lancashire Football Supporters podcast. I want to talk about testicular torsion. And the reason that I brought this up is because I think this is something where you can make a huge difference. So testicular torsion occurs when the testicle rotates and twists the spermatic cord, and then that cuts off the blood flow. And then, if you don't do something, that testes dies. So they usually present with sudden intense pain. And what's interesting is NCPOD, so this is a national morbidity and mortality group, did a huge report about all the cases of testicular torsion throughout the country. And the thing was, it was really surprising. The first thing they said is, we really need to increase public awareness. 65% of boys and 35% of their parents didn't recognize there was a problem. And only 73% of patients presented to a healthcare worker within 6 hours. And when they say they didn't know there was a problem, probably the boys knew there was pain, but they didn't tell anybody and nobody did anything. And the reason that this is important is because in a big systematic review, if you're going to operate and untwist the testicle, if you do it within 6 hours of onset, then you have a 97% success rate. But by 18 hours, you're down to 79%. And if you wait more than 24 hours, then there's only an 18% chance of saving that testicle. So this is a time-dependent emergency. And the other thing is you need to send patients to a hospital where surgery can be undertaken. So in our case, it may be that there's no point going to, I'm trying to think, NSEC. They would have to come to us because we have the pediatric surgeons. So that's just a quick reminder. It's surprisingly common. So it does actually present in babies, but most commonly between 11 and 18-year-olds. So it's 1 in 800, which is relatively common. Remember I said you've got 6 hours. They present with sudden onset of unilateral testicular pain. And the really important question is, does it ache even when they're resting? So even when they're lying down, it still aches. They often get tummy pain and nausea and vomiting. There's an increased risk of torsion if you have an undescended testes or in children with neurodiversity, and that's probably because they can't communicate. And there's this nice twist score. So you can, when you examine them, these are the things that you're looking for. Is the testicle swollen? Is it hard? Is there an absence of the cremasteric reflex? I'm not going to describe to you how to do it, but guess what? It's on our website. Is the testicle sitting in a different position, so riding high, and are they vomiting? Now, if we see them and they're low risk, they would go home. Intermediate risk, they'd get an ultrasound. And high risk, they go to theatre without the ultrasound. They just go straight. And this is our parent page here. So it's like save the balls. Can you see that? So you've got have you got a strong ongoing pain? Have you got tummy pain? Are you vomiting? And does it ache even if you're resting? And it tells you what to do. So if you have testicular pain and any of the symptoms and it's severe, you need to tell an adult and go to the emergency department. If it's not that severe, make of the note of the time that the pain starts. And if it goes on for more than an hour, go to the emergency department. If the pain goes away within the hour and it wasn't that severe, you can see your GP because it could have twisted and untwisted itself, but you still need to get something done. So I think this is a great page and it's something that's not talked about. So all you school nurses, I'm hoping that you're going to go out and save balls. I thought I'd keep with the theme of balls. And I think there's lots of school nurses here. So head injury and concussion. I put this up because the guidelines have changed quite recently. And I think it's something that we see a lot about. So we have a head injury pathway for professionals. And again, think about this history. So what was the mechanism? We would see anybody who'd been in a high-speed road traffic accident or had a fall from more than 3 meters. You need to think about asking about, was there any loss of consciousness, any vomiting, fitting, persistent dizziness, amnesia, either antegrade or retrograde, so before or after, worsening headache. Does the person who was hit on the head have a clotting disorder they know about? Just do a quick assessment. Are they alert? Are they confused? Is there any lumps or bumps on their head? Do they have any focal neurology? And is there any concern about C-spine? So always think, were they in a traffic accident at high speed? So we would see confused, we would see anybody with witness loss of consciousness more than 5 minutes. Anybody with obviously, drowsiness or post-traumatic seizures, so seizures afterwards. And obviously we'd see fractures. But I think this is really useful. I think the amber ones are really useful as a quick reminder of what we worry about. I think you probably do the right thing. I think head injuries you probably are used to seeing. I often say for schools, the schools should be using Healthier Together. If their child gets thumped on the head by a ball, they should just send the head injury link straight to the parent, because remember, you can text it to the parent and they can look out for these symptoms themselves. I wanted to touch a little bit about concussion. So concussion is if you had a loss of consciousness, visual changes, confusion, or memory loss at the time of the accident, right? And it's really important to follow the advice to recover. And we would expect all the symptoms to settle after a couple of weeks. So the kind of things you get after a nasty head injury are headaches, dizziness, ringing, being not quite right. That was if they had a fit at the time. Blurred vision, being dazed, being sick, and having difficulty concentrating. And this is our recovery guidelines. This is really important. The treatment for concussion is rest. So in the first 24 hours, they should have complete rest, not even brain activities, which is reading, watching TV, playing computer games. After 24 hours, you can reintroduce brain activities, but they should be observed for 48 hours, and obviously they can have pain relief. The thing that I think we get a lot of questions is about returning to school and sport. And it's really interesting because Anna Bruff is our trauma lead, and she does a lot of work with our trauma nurses. And we found children who were off school for like 6 weeks. It's actually unusual for children to need a long time off school after concussion. So I wouldn't be surprised if they missed a couple of days, but after that, they should be able to return to school. They might be tired and they might have difficulties concentrating, so they might need a sort of graded return, or they may not be able to do homework, but there's no reason they shouldn't go. Sport is a bit different, and particularly contact sport. So I'm thinking about rugby, football. So they should come back. They should come back to school, but they shouldn't start sporting activities for 14 days if they've had definite proven concussion. And when they start sport, it should be a graduated return. And we've got links to what those could be. But there's no reason they shouldn't get back to it. But it may be, if it's a really high physical sport like rugby, that it might take them a bit longer, like 3 to 6 months, to do some of the more dangerous things. So we've got a whole page on concussion. I think it's really helpful. Those of you in the minor injuries unit, we just suddenly realized we didn't have much about minor injuries. And I actually am really bad at these because I never did the emergency department. So I find them really useful. I think it's really useful for parents as well. Like, for example, which cuts need to come in, what to do after a burn. I'm not going to go through all of these. You can have a look at them. We put buccal fracture in because there's been a recent change and they don't need much. So I just picked out eye injuries because I think eyes are, it's an eyeball, sorry, sticking with balls, but eyes are sort of yucky. So how can you care for eye injuries at home? You need to think about washing out the affected eye if it's been exposed to any chemicals or fine particles. So think of sand or grit. But don't wash if there was an injury of significant force. So imagine that's a sort of squash ball to the eye, or if you can see a cut in the eye itself. Remember to use clean water. It doesn't need to be sterile. Clean is fine, but not hot. So it can be a tap, a shower, or bottle. You need to hold the eye open and run water over it for at least 20 minutes, and they'll need some pain relief. And then just put a light covering so that they don't rub it. Better still, we need to think about preventing these kind of injuries. So thinking about whether they have goggles or glasses or unbreakable glasses, keeping chemicals and products out of reach. This is a real big one for younger children. Nerf guns, Nerf gun injuries. So all those boys running around with Nerf guns, it's always about like having rules, not pointing guns in people's face, age appropriate toys. Safety equipment that meets national standards. This is really important. We've seen a lot of minor injuries with funny toys that were imported from China that don't meet safety standards. And at the bottom, this is so important, be wary of dogs that are not known to you. So letting children run up and pat dogs that they don't know. So I've talked about sort of acute conditions, and now I'm going to move on to some things that happen anyway in teenagers and older children. And really, a lot of my talk, I thought puberty is such, guess what? We all go through it. And it causes so much angst. So I thought I'd do a quick update on puberty. And also, we've got a whole load of really good resources. So in case you forgot what puberty is, under our puberty section, we have a Tanner growth chart. So you can look at this and stage boys on, I can't do this, that left side, and girls on the right side to see what stage of puberty they're in. Size matters in puberty. I don't know if any of you knows what this is, but it's an orchidometer. So this helps you measure the size of testes, and we use it a lot in clinic. It doesn't matter if you don't have one. If you have one, it's really useful. So the 3 green small ones are prepubertal children, like size 4 to 6 mils, that's sort of early puberty. 8 to 12 mils is later puberty. And the red ones means they're literally through puberty. And I'll show you why that matters in a second. So in boys, the first sign of puberty is an increase in the size of their testes to greater than 4 mils. And then increase in penile size and pubic hair development. And the growth spurt in boys comes later than females. So it's usually a year after puberty begins. So remember that, because I'm going to talk to you about delaying growth in a minute. In girls, it's the other way around. So they get breast bud development first and then some pubic hair, and their growth spurt occurs early in puberty. And at the moment, the average age of onset of menarche is about 13, but it is related to weight. So bigger, taller, heavier girls will go into puberty earlier. Pubic hair can develop before the onset of puberty, and I'm going to talk about that. That's adrenarche, because of adrenal androgen generation, which starts before the onset of puberty, because I get a huge number of questions about that. So the 2 times that I see children is, first of all, puberty, it's too late. So it's the small boy in the class. Everybody else has got a deep voice, and there's always one in the class. He's really small, and he's absolutely fed up of being the smallest boy, and everybody else is crushing him when he's playing football or rugby or whatever. And they get really upset about this. So if you see delayed puberty, have a look at the Tanner stage criteria. Ask them, have you had a growth spurt? Have they started growing? Check about any change or excessive exercise patterns or weight loss, because you're thinking about anorexia, possibly in girls. Other symptoms, tiredness, constipation, cold intolerance, or weight gain, because it could be a thyroid problem. And the things to worry about if you've got delayed puberty are asking about headaches, visual problems, confusion, personality change, polydipsia or polyuria. And that's because it's delayed puberty that might be a tumor in their head, in their hypopituitary axis, hypothalamus pituitary axis. Now, to be honest, those are very, very rare. So constitutional delay of growth and puberty is the most common. So I see 90% of those small boys I was talking about, it's just them. And if you ask them, their dad goes, yes, I went through puberty really late. So it runs in families, it's transient, and they will start puberty. I tell them 2 things. Number 1, if you go through puberty early, once you've gone through puberty, you stop growing and there's nowhere to go. So going through puberty later gives you longer to grow. So they like hearing that. If they are really impacted, if they're really upset about it, you can refer them to the endocrine team and they can treat them with testosterone. It doesn't necessarily put them through puberty quicker, but it makes them feel like, oh, I'm a boy, and they don't mind so much. They feel the same as the other boys. And just the other things, the delayed puberty factors, those are the ones you're going to want to refer. But think about chronic diseases. So do they have cystic fibrosis or something else? Excessive exercise. So that's linked to anorexia, malnutrition, stress. We have a fantastic chart here that the endocrinologist made us of all the causes of delayed puberty. You do not need to remember them. But if you get presented with this problem, you can have a quick look to remind yourself what we've talked about. So, puberty that's come too late, that's the small boys. Most of the time, they just need a bit of reassurance. Oh, sorry, I was just going to go back and say, remember with the boys, the one thing I do is if I examine them and I find their testes is bigger than 4 mils, I'll say, you haven't noticed, it's starting already, just be patient. It won't take long. So if I see a small boy, but their testes is actually already getting into that pubertal range, I can reassure them it's on its way. The other thing we see is puberty too early. And really, I'm talking about body odor and pubic hair. So we get a lot of referrals for young kids, usually girls actually, where the parents are worried about body odor or they've seen a few pubic hairs. And this is known as early adrenarche, so premature adrenarche. And this is what I was telling you, is that the adrenals start working. And as a result of this, you see a child who has a few pubic or axillary hairs, some body odor, and possibly a few spots. So you just need to follow this flow chart. And this is actually one of my favorite. So this is very, very straightforward. First of all, you need to find out, are they under 8 or in a boy under 9? So if they're older than that, it's normal and we're not interested. If they're younger than 8 in a girl or 9 in a boy, just ask 3 different questions. Do they have any breast development or testicular enlargement? In which case, this is early central puberty and you can refer them. But if they don't have that, do they have any clitoromegaly or penile enlargement? Because if you see that, you can definitely refer them. If they don't have that, this is under 6 for girls and under 7 for boys, in which case, yes, it's just normal premature adrenarche. And you can give this information to the parents and reassure them this is not puberty, this is just adrenarche, and you don't need to do anything about it. If they're really worried, we just sometimes measure their height and reassess them and reassure them. So again, don't panic. It's just that the next time you see somebody who comes in and says, my child's got a pubic hair and they're only 6, think, oh, I know what to do. I just follow the chart. So premature adrenarche, really useful. Moving on, I just wanted to show you, we have a really big young persons section. And we've put quite a lot of things in it. And I think that I'd really like to get them used more. So we've got a whole load of different sections on growing up, mental health, sexual health, what's the harm. And I'll just show you a few. I picked what's the harm because this is what I worry about as a parent. I have teenagers. I'm always worrying about them drinking alcohol, taking drugs, getting tattoos, and having sex and vaping. So there's the facts here. Remember, you can't tell young people anything, but if they want to look on a website, they need to be given a reliable website that gives them good information. Alcohol poisoning. One of the things I find is there's a lot of information about giving up alcohol or not taking alcohol, and that's fine. But we've had a couple of tragic cases. It was after lockdown, and a young girl went out. They obviously hadn't drunk in lockdown because they'd been at home. They immediately went out and went to one of these places where they drank loads and loads of cocktails. Their boyfriend brought them back, took them home, and their parents put them to bed. And when they came and found them in the morning, they were dead in their bed, which is an absolute tragedy and avoidable. So think about the symptoms and signs of alcohol poisoning. So confusion, slurred speech, loss of coordination, vomiting. And I know you think, well, some of those come with being drunk anyway, but irregular breathing, being unresponsive or unconscious. And the question is, what do you do, or what does any young person do? Keep them sitting up or put them in the recovery position if they're unconscious, give them water, keep them warm and stay with them. Don't leave them alone. Don't leave them alone. Don't give them coffee and don't put them under under a cold shower. And the most important thing is, if you're not sure, take them to the emergency department and get them assessed. It's better to be safe than sorry. And we know that this happens and we would rather avoid any awful tragedies. So this is something that I think that young people need to know before they go out drinking. They, of course, are not interested in the harm page at all. They're interested in this page. And this was really interesting to me because when we went out and asked young people what they wanted information about, I wanted to tell them all about safe sex, but actually they wanted to know about bullying, exam pressure, and looking after their skin, which I considered to be terribly unexciting. And I think that's because I'm so old, I've forgotten. When your whole life is school and somebody's being unkind to you at school, it means everything. So these, as we call them, low-level issues are actually really important to young people. And I think that getting good information and clear information and help is really important. So signposting, I'm trying to get the schools to signpost in their PHSE lessons and their health and social care lessons to use this more often. We have lots of pages with advice about LGBTQ, about coming out, abuse, information and gender identity, which is really important. But I wanted to show you this. Remember, if you need to send information, you use the yellow box at the top. But we also have this, the red button up here, Recite Me. That will translate this page into 100 languages, and it does read aloud in 60. So that's really, really useful function. And the young people asked us to put another button which says leave the website quickly. So if they want to look something up and then somebody comes in, they can leave the website very quickly, and then it just takes them back to a screensaver. So I just wanted to show you that feature at the top. So in summary, we've been through sepsis. I've talked about red flags. I've talked about listening for parental concern. I've asked you to think about saving balls and that how you've only got 6 hours from the onset of the pain. We talked about fits and faints and how it needed a good history, examination, and 1 ECG. Injuries, we've tried to do a lot more about head injuries. We've got really clear advice for concussion, when to go back to school, when to go back to sports. So remember, that was 14 days after the head injury, they can start sport, but graded return and no contact initially. Eye injuries, when to wash the eye, when not to wash the eye. Puberty, which I see a lot of referrals, so constitutional delay in growth of puberty in boys. So the small boy, do an examination. If you can bring yourself to do a testicular size, you may then be able to just reassure them that it's actually already started and they will grow very soon. If you see girls or any children with body odor and 1 or 2 pubic hairs, is it premature adrenarche? You know how to follow that down. Just briefly going through the young person section, I just ask you to just go and have a look around it, think about it, think how you could use it and promote it. I'll take any questions. Thanks to Laura and Anne, who do all the hard work, and Alex Battersby, who's my co-clinical lead. Our ask for you is that you go out and champion using Healthier Together. You help parents and carers to download it, and share the resources with wider colleagues, absolutely with schools. We're really keen to do work with schools. Stay in touch, and as Laura said, if you haven't joined our network, here's a QR code for you to do that. And then just get in touch with us and see how you can be part of the Northeastern North Cumbria network. So you can also, we also have loads of resources. So if you need posters or cards, please ask Laura, because she can share them with you and send them out.
Thank you. Thanks very much, Emma. Does anybody have any questions or anything they would like to ask? Or this is your opportunity to utilise Emma while she's on the call.
What's this? Oh, there's something here. What's this I'm reading? If the GP practice have onboarded, if the GP practice have onboarded with the app, an online consultation route is enabled. Is this you telling people about?
Yeah. So it was just how the app works. Because Helen had asked to clarify about what you meant when you said send a message to your GP in the app. So obviously the practices have to be onboarded, which I've shared the information to Helen directly via email about how a practice can onboard to offer the online consultation. Because if a practice isn't onboarded, it just offers call the practice via telephone.
The school, I saw there were a lot of school nurses. What sort of things are you being asked about? Is there anything that we haven't covered, or is there topics that you would like but haven't found? Where are my school nurses? I'm going to have to go up because I can't remember all your mates. Thank you, Margaret. Will you be doing more of these? Yes, Margaret, we have 2 booked in March, which Alex Battersby is. More sexual health. Yeah, I'm with you on that. I did a sexual health job, and I'm very, I think it's such an important topic. Margaret, my children die because I talk about sexual health all the time. And I think it's really important. And I think that British people are very bad about talking openly about sex. So talking about safe sex, talking about consent, talking about different types of sex, talking about the risks of oral sex and anal sex. So I think that's such an important topic. Have we stopped recording? Are we still recording?
No, we haven't. We're still recording. I was just obviously with questions to ensure we've got them recorded.
Oh yeah.
Has anybody else got any questions or any topics you would like us to cover?
Let's ask what do you get asked? I want to know what the school nurses get asked about, because I'm not a school nurse, so I never know what you get asked about. I'm going back up. I've got Claire.
So we've got
Claire
Helen.
Cotton. Oh yes.
Helen's
Neurodiversity.
Yeah, neurodiversity, children's mental health.
Leanne, last week I did a bit about. Were you here last week?
Yes, yeah. It's just one of the things that kind of comes through the most
all the time.
Constantly, in single point of access from parents, but also in drop-ins for young people. Sort of, it probably comes through really from young people quite often as mental health first, and then as you talk through. But it's about just supporting them whilst they're waiting assessment. That's
absolutely
the main thing.
Leanne's a really good point. I think the problem is for us is that the services for neurodiversity is so overstretched that the waiting lists are like 1 to 2 years. Actually, I know 5 years for some of the older ones. So the question is, what do you do in the meantime? And I know I covered it last week, but hold on, let me see if I can be clever and share. I'm going to see if I can share live.
I've just got a question in the chat as well. Can I check if anyone knows, can children now access the crisis team through 111 instead of SIPS? Oh, I'm not actually sure about that. I don't know if anybody else is aware of that. We could check that up though, Lindsay, and ask and try and get back to you.
For those of you that weren't here last week when I did the younger children, we really appreciate that actually all these families are waiting such a long time to get assessed. And the question is, what do they do in the meantime? So we have this page here on neurodiversity. And I often say to them, I can't make this diagnosis for you. I'm not going to make it in my clinic and I can't make it, but you can go on this, you can click on these links and you can go through the criteria and then you can share them with the school, because remember, they do need to have some information from 2 different places, and then make a list of your concerns, and then you can have a better referral. And then the question is, what do you do while you're waiting? For the younger children, I'm just clicking on this local resources. We've got these videos from Helen Leonard, who is one of our autism consultants, and it goes through toilet training, eating, well-being, and sleep, and also navigating the system. And I think that really helps parents. So I think sort of breaking it down into what's the problem. For the older children, absolutely, I would 100%, we've got really good ones on sleep and anxiety. So I would always have a look at our sleep pages. There is sleep for teenagers, sleep for health and hospital, healthy sleep, here we go. We do break it down. I think that what surprises me, here we go, teenager sleep advice. What always surprises me is that parents don't seem to recognize that even teenagers need up to 10 hours sleep. So they need a lot of sleep, although their natural circadian rhythm means that they're often going to sleep really late, like midnight, 1 o'clock, and then wanting to wake up at lunchtime. But this goes through good routine, screen use, sleep phase disorder. I've seen this quite a lot. This is when they do what I've just explained. They go to bed at midnight and then wake up at 12, and then they end up by pushing it later and later till they're going to bed at 2 or 3 in the morning and waking up at 3 p.m. and missing school. So I've seen 2 or 3 like that, and actually you just need to move their bedtime back by 15 minutes each night and be tough about it. They also need to get out, be in the daylight, and do some exercise. I'm slightly going off piece, but I do think we get a lot of calls about that. Okay, any other health things, school nurses? Any other health things in teenagers that you see? I think I've frozen.
I don't think anybody's got their hands up or questions.
Please put in the chat. We really like to get some feedback on whether these sessions are helpful and what you would like next. So if you drop a message into the chat before you leave and say, how did this session cover things that you wanted, and what would you want for other sessions? That'd be great.
And we'll obviously look into those sessions that have already been raised for what professionals we can get to support. Okay. Thank you. So I'm going to stop recording the session now.